Good afternoon. Hello, and welcome to today's webinar on financing medical respite care, a practical discussion to ensure sustainability. My name is Barbara DiPietro. I'm the Senior Policy Director for the Council, and I'm acting as moderator for today's webinar. Please note that this webinar is supported through a cooperative agreement with the Health Resources and Services Administration at HHS. The session is being recorded, and the recording will be posted to our website within a couple of days. So the slides and this recording will be available, and I anticipate that is a frequently asked question, so we'll put that right up front. This is a 1-hour presentation. We will save the last 10 or 15 minutes for questions and answers. So below the slides, what you should see on your screen is a chat box. That's for participant questions and any technical issues that you might have. So if we're talking about something that you'd like more information on at the end, please type your question into that box and we will save it. If you have any technical issues, you can either type it into this box here, or you can call the Council's office at 615-226-2292 and ask to speak to Michael, who can help you. Again, this will be posted on the website. You will be sent a recording. Really excited about this topic because over 200 people registered for this webinar today, which during the summer I think is really remarkable. I think that we get a lot of technical assistance questions at the Council and on respite, and one of the biggest things is how do you finance this? How do you start putting together a plan to be able to bring this up? And so we wanted to have a focused discussion today just to really kind of delve into some of the financing pieces. So with that, what we'll talk about today is just a little basics so that we all know what we're talking about. What is medical respite? What's the rationale for why you would have a medical respite program either at your site or in your community? What are the financing approaches that are most commonly used in programs that are existing today? Some hot topics that we've been currently looking at the Council and that we've seen emerge in our local communities. We'll talk specifically about two very different programs, and we'll have a discussion with the experts in the field about what medical respite is looking like, how we're financing that, and some of the things that you might consider as you're moving forward in doing more respite in your community. Also want to put in a plug to look out for a policy brief that we will have out soon on financing medical respite programs. This is at HRSA for review, so we're excited about having that on the street soon. Really excited to talk today with the experts in the field on medical respite. Julia Dobbins is a project manager with us at the Council. She's everything respite. She's really been taking the helm of a lot of our projects and initiatives around this, so excited to have her as part of our discussion. Brenda Goldstein is the Psychosocial Services Director at Lifelong Medical Care in Berkeley. One of the things I really love about Brenda's program is that it's a very straightforward program that no matter what your state looks like in terms of its Medicaid program, whether you expanded or you didn't expand, or whether you're working with a lot of resources, a lot of partners, Brenda's program is really the kind of thing that is tangible for everyone to be able to implement. So I think that's an exciting model, particularly if you're just starting out. That might be something that is not as intimidating as Brandon's program. Brandon is the CEO at Circle the City in Phoenix. He's also the chair-elect of our Respite Care Providers Network and our steering committee. Brandon's program is very comprehensive. It's got lots of different funding sources. They're able to maximize billing as well as grants and a lot of other things. And so I think this kind of shows a range of programs that we've got in communities, but by no means is the only types of programs available. So we wanted to talk a lot about that today and what might work for you in your community. I just want to start off with just some basics. And so what is medical respite? These are the formal definitions that we've been working with, acute and post-acute medical care. Essentially people who are in the hospital and no longer meet hospital-level need for medical care. But there's no safe discharge for people who would otherwise be discharged to home for those that don't have a home. And so we know, of course, that it's illegal to discharge and make an unsafe discharge to the street. Federal law prohibits that. And so really hospitals often sometimes get stuck is what do you do when someone is still sick? Is injuries or illness post-operative, and where can they rest and recover? It's important also to remember that medical respite care is not a skilled nursing facility or a SNF. It's not a nursing home. Those are typically a much higher level of care than what medical respite is. Assisted living is the same thing. Usually those are very regulated levels of care within states. Medical respite generally is below that level of care, and it is not supportive housing. However, medical respite can complement all of those types of programs in your community and serving as part of that continuum of care as people kind of move in between venues for where they're receiving services. And it's important to note that we know of about 80 different programs in the country right now that are medical respite. We maintain a directory to the best of our ability on our website on where those are located. And really what we have found is that there's such a diversity in how these programs look. And so when we even think about size, like people ask us all the time, how many beds should I start with? What's a typical program look like? And really, while most programs have between 5 or 35 beds, the average size is about 21. The programs have got everything from 1 to 100. So really it'll look a lot like what you need it to look like in your community. When we think about what the facility type looks like, again, there's a big range. There's standalone facilities that are really quite comprehensive and very medically based. But then you also have shelter-based programs or programs in transitional housing or public housing. People use motels or scattered site placements for this. So again, that can look very different. When we think about lengths of stay, so how long is someone in a medical respite program? And so how do you plan or staff to that? Again, this really is dependent on the needs that you've identified, maybe some of the acuity or the medical types that you want to take into the program you put together. And so an average might be around 30 days, but it can range from 5 to 60. Some outliers might even be as long as 6 months or longer. And so thinking again about what's the type of length of stay you'd be able to sustain in your program. When we think about the level of staffing or the types of services, again, we know those go together. The higher the acuity you're able to take into your program, the more rigorous the medical staffing you might want to have. And so it can look lots of different ways. Some programs are very scaled down, very social work and case management based. Other programs have got higher level credentialed medical providers, MDs, nurse practitioners, physician's assistants. But very typically you will see some combination of a nurse, a case manager, a therapist perhaps. Community health workers are also very common in trying to do some peer navigation as well as people get stable and start getting ready to transition into something better ideally than where they came from. So the idea is that we're getting people from respite maybe into something better like supportive housing where possible. And then lastly, admission criteria. So I've talked a lot about what kind of medical services that you might be able to accommodate or what kind of acuity, but really your services can be as much as you're able to staff to. And so part of this might be typically programs are looking for medically stable folks who can do all of their activities of daily living. And so people might need help with medication assistance, but that may or may not be something that you're able to do. So thinking about, again, what your program would be able to tolerate, particularly within the venue that you're in. So sometimes in a shelter-based program, you've got more limitations than if you were in a standalone facility that you ran and you set the policies. Typically, however, most medical respite cannot accommodate IVs or oxygen tanks. And one of the things that I think are real challenges that many grapple with are really significant mental health issues or serious substance use disorders and how that might be able to be accommodated or not, again, depending totally on the kind of environment that you want to set up. So again, that's a way of just saying they can look lots of different ways. There's a lot of parameters to consider. The rationale for medical respite, though, I think is really strong. I think one of the things that particularly in states that have not expanded Medicaid, where your hospitals are particularly in a pinch, but also all states and all hospitals are looking at being more cost conscious. All hospitals are looking to reduce their readmission rates. There are financial penalties for hospitals if they're doing excess 30-day readmissions. And so they're looking at who's coming through again and again. Where are those lengths of stay? Where can those costs, where do costs not actually accrue toward additional quality of care? And so as people are looking at this in our healthcare systems broadly, as well as in the hospital specifically, you're going to see a pretty strong case for a medical respite program. There's a lot of emerging research that shows, people who are homeless have got more frequent hospital stays, more frequent ER visits, longer lengths of stay, longer readmissions, and all of this comes at a larger cost to the community. And regardless who the payer is, at the end of the day, it doesn't add any quality of care or improved outcomes by staying in the hospital. And at the end, too, the right thing to do is to get people in an appropriate venue of care. And where possible, of course, that's housing. But where that's not possible, again, we need to think about some of these innovative solutions that can serve as a bridge between venues of care. We did just a quick survey. We've done a survey of how the medical respite programs that we know of are funded. And because of the impact on hospitals and the lengths of stay and all the things I just talked about, it's probably not a surprise that hospitals are the most common funding sources for putting together medical respite. And you can see here that there's a pretty wide range of places that you can get funding. But again, hospitals and private donations certainly are more than half of programs that got that type of funding. And I just want to hit really quick, again, hospitals have got numerous areas where they might draw on some revenue to be able to fund this. Community benefit funds as part of their mandated needs assessments, operating funds, or many hospitals have a foundation arm. Sometimes you can do a contract or an MOU with them as the vehicle for how you might get some payments. And that might be on an annual grant or a per diem basis, again, depending on how you set that up. Your private philanthropic institutions in your community are often looking for these kinds of innovations that can fill gaps, particularly where there's nothing happening now and people really want to get something going. That can be a great way also to get unrestricted funds, again, for one-time only cost or renovations. So thinking innovatively about how you can combine some of that funding. State and local government, there's a variety of sources that you might pull from, the social services funding or the HUD continuum of care. Lots of those are possibilities. And then with HRSA, again, if you happen to be affiliated with a health center, that makes for a natural a collaboration or a service provider that both can pull in the HRSA funding, but then also some of the staff. Medicare and Medicaid, this has been increasingly an option, particularly in expansion states, where more of the population might have Medicaid in particular. And then so that might be for a statewide benefit, and a number of states do have a statewide medical respite benefit that they're able to bill for in their program. However, managed care plans, so this is emphasizing the importance of developing a relationship with your plan, can do a lot. If per member per month, there's some innovative payment mechanisms that really are just for that plan in your community. And this can be a great way of testing things out to see if they work. So I just hit a lot of material really fast. I'm excited to be having this conversation just about medical respite because I think that this is a really a burgeoning movement of recognition that this is a gap in continuums of care. And at this point, I'm going to hand it over to Julia Dobbins so she can talk a little bit about some of the hot topics we've been seeing. So with this, I will stop talking and I will hand it over to more of the experts. So Julia, you take that away.
I don't know about that, Barbara, but thank you. Hi, everybody. My name is Julia Dobbins, and as Barbara said, I am a project manager with the National Healthcare for the Homeless Council. I staff the Respite Care Providers Network, or RCPN, here at the Council, and part of my role includes responding to medical respite-specific technical assistance, or TA requests. And we're seeing more and more people seeing that medical respite is an essential piece of the continuum of healthcare for the homeless. So medical respite really continues to be one of our top TA requests. And specifically, people want to know how to start a program in their community. Financing respite obviously is a pretty essential piece when you're considering starting a program, so it comes up in almost every conversation we have about respite. One of our challenges when it comes to providing TA is that, as Barbara said, there is really no one-size-fits-all medical respite model. Most respite programs are very community-specific and function to meet their own community's unique needs. Additionally, because right now there is not one clear funding mechanism for respite, program design and services offered all really depend on the resources available and what partnerships you're able to develop. So the big TA question we always get, and I'm sure this is no surprise to you, is, so how much is this going to cost us? And do you have an average budget that we can just reference? And this is really difficult for us because, unfortunately, the answer is no. First, because most programs are really shy about sharing their dollar amounts, and you'll see later on that Brandon is one of our outliers. Secondly, like I said earlier, it's just so subjective and really dependent on your community. So what we've learned over the years is that it's really useful for us to connect people with each other. So we maintain a directory of medical respite programs around the country, and one major project we're going to be working on in the new fiscal year is to make that directory more interactive and more in-depth so that it can be a better resource. So, for example, if you want to know how many respite programs in the country get funding through United Way and what those dollars support, you would be able to search for that. Or let's say you live in a town with less than 20,000 people and you want to know what type of facilities or staffing other programs have in cities of a similar size, that would also be something you'd be able to search for. So that's something coming down the pike in the next year that we're really excited about. Another exciting project the Council is engaged with is a Center for Medicare and Medicaid Innovations Award. The focus of this project is to establish a standardized model of care for respite that includes case management, patient engagement, transitional care, and prevention. We partnered with 5 respite programs across the country for this 3-year study, and the project actually ends in August of this year. So findings and publications are forthcoming, but it's our hope that the results of this study will be another resource for you to use as you speak and meet with potential funders. The Council has been really deeply involved in promoting medical respite care, and one of the major projects that have grown out of this commitment is the first ever set of national standards for medical respite care. In 2011, I believe the steering committee of the RCPN began developing the standards really in an effort to improve quality and consistency across a wide range of programs, also to improve opportunities for research and potentially and hopefully for federal funding for respite. There are 7 standards that focus on things such as care coordination, program facilities, quality improvements, and really the standards serve as a framework to help respite programs operate safely and effectively and to promote program development and growth. So for the sake of time, I'm not going to go through all of the standards individually, but they were finalized and published in October of 2016. They're available on our website, and they truly are an outstanding marker of quality that I would encourage you to build your programs around. In addition to the standards, we have several other great resources on our website, including a practical planning guide and a planning workbook, which includes sample budgets, unfortunately without the dollar amounts, of course, but still helpful in considering what line items to include in your budget. Also in our toolkit, we have sample operational plans, sample MOUs with hospitals and shelters, intake forms, job descriptions, lots of different tools that you don't have to reinvent the wheel. Also, honestly, it's been my experience that people who work in medical respite are generous and kind with their knowledge and experience and resources. So if you want to be connected, please feel free to reach out to us and we will help you get connected. Brenda and Brandon are prime examples of folks who work in respite who generously share their time and their knowledge. And with that, Brenda, I think I'm going to turn it over to you to tell us more about your program.
Thank you, Julia. Good afternoon, everybody. My name is Brenda Goldstein. I work for Lifelong Medical Care, which is a federally qualified health center in the East Bay of the San Francisco area. And I was tasked with giving a brief overview of a very simple respite model, what I call a stripped-down version that got up and running fairly quickly. We were approached by a hospital system that has two large hospitals, one in Berkeley, one in Oakland, where there are large homeless populations. They wanted to get a respite program up and running within 3 to 6 months and asked if we could help them do that. We ended up developing a very simple model that really is mainly funded through one simple contract with the hospital. The hospital pays us for a 6-week post-discharge stay. We started out by offering 5 beds and have expanded to 10 beds across 3 different facilities in our geographic area. And we actually don't own or operate any kind of facility that operates 24/7. So we needed to subcontract for those beds, and we approached partners in the community who run transitional housing and residential hotels. And we have those relationships established because we work in supportive housing, but found that there was a lot of openness to looking at how the beds that they had could be used to serve a respite program. We were also very concerned not just about the bed but about food, and didn't want to have to get into worrying about food service or bringing our clients food, so we made sure that those facilities were places that could include meals in our subcontract with them. We started out with a half-time case manager, a non-licensed person who had experience working with the patient population, and increased that position to full-time when we went to 10 beds. We also have an RN who is, her main function, I would say there's 2 big things that she focuses on. One is being the gatekeeper to work with the hospital discharge planners to assure that the people who are referred into the program are appropriate for the program and are likely to have success once they're transferred out of the inpatient unit at the hospital over to one of our facilities. And then the other is to really provide backup to the non-licensed case manager, to provide training around basic health issues, to be there when there are questions about the person's health status. She sometimes goes to the hospital to meet with potential patients before they get discharged, and she's available to the facilities just during regular business hours if they have questions. She periodically goes out to the facilities as well to do a visit, but that's not a routine part of her work. We also included funding for flexible spending for our clients, a lot of money that goes into transportation to get folks to the facilities when they're discharged, back and forth, particularly to follow up medical appointments. We do provide some supplementary food. Often the person gets discharged out of the hospital with hardly any belongings, and so we'll help them out with clothing, toothbrush, toothpaste, anything that they may need in order to make their stay in the during the 6 weeks as comfortable as possible. And the average stay is probably about 4 weeks. We have people who stay for a day and others who at 6 weeks don't want to leave, but typically 4 weeks is about average. We do not do any billing beyond our contractual billing. We purposely set up the program initially to make it as easy as possible, and as an FQHC, neither RN nor non-licensed case managers are billable providers. So all of our costs are covered by our contract, and we do no billing under our PPS rate or to any other entities. So what are the services that we actually provide within this construct? I think of our model as being a social respite program as opposed to really a strong medical approach. We don't actually provide any medical services by our staff on site. If the person needs assistance with, for example, wound change, diabetic teaching, et cetera, we typically will work with the hospital at the discharge time to order home health nursing as needed, and to facilitate the nurse getting to the site, making sure that the client is actually at the site when the appointment is scheduled for that visit. But really our main focus is on supporting the individual to reconnect with their primary care provider, to get attached to services around behavioral health, whether that be mental health services or substance use services, linking them with community resources of all kinds, doing an assessment of what their benefits are, and assisting with transportation. And all of that work is done by the case manager. Over the course of 6 weeks, there's a limited amount that you can get done. So we are sure to prioritize with the client what's most important. And for the hospital, what's most important is that the person doesn't get readmitted to the hospital, and that they get linked back to the primary medical provider and any specialist appointments that are needed post-discharge, and so we do focus on that. We have a very strong harm reduction model, as I think most respite programs have, and being in an area where there is major housing crisis and getting people into any kind of housing, whether it's transitional or permanent housing, is extremely difficult and takes many months. It is not that common for our respite clients to actually discharge to permanent housing. And this was something that I had to wrap my mind around initially. We don't have funds to keep people on longer than the 6 weeks. We don't have any housing that we can put them into. So we do everything we can while the person is in respite to link them up with some discharge plan. Maybe there is some family or friends that they can go to. Maybe they're willing to go into a shelter. Perhaps a bed doesn't open up in the transitional facility that they can slide into. But many of our clients actually do go back into homelessness. And we don't like that, but that's the reality of our environment, and we're looking at this as harm reduction, and the fact that they've had an opportunity to recuperate in a bed 24/7, get connected with a case manager, and reestablish in primary care is the best that we can do for now. We are getting folks to fill out applications to get into our coordinated entry system, so that they are at least in line for housing when it becomes available. We also spend a fair amount of time, and this is mostly the RN, managing pressure from the hospital and from skilled nursing facility discharge staff, because there is tremendous pressure on the direct service staff in the hospital to get these clients out of the hospital as quickly as possible. And we have to be spending some of the resources that we have in staffing to actually make sure that the right people are getting to the beds, and that it's not just because the hospital staff want the people to be out of the hospital, but because it's actually appropriate for the person to be going into a respite bed. And then we track and report on readmits, linkages to primary care, housing status at discharge from respite, and have worked very closely with the hospitals around looking at the outcomes from the project, promoting continued attention to the project, and also putting resources into maintaining our relationships with the hospital discharge staff. I think I will go ahead and pass you along to Brandon, who's going to be talking about his program, which is a much more sophisticated model. Brandon, all yours.
Thanks, Brenda. Sophisticated is a strong word, but I appreciate it. It's gracious. Circle the City. My name is Brandon Clark. I should say I'm the CEO of Circle the City. Circle the City is a healthcare for the homeless program in Phoenix, Arizona, and as part of our portfolio of programs, we have a 50-bed freestanding medical respite center. Arizona has been occasionally accused of being backwards, and I think Circle the City is probably no different. To my knowledge, I believe we are one of very few, if not the only, nonprofit organizations in the nation that started with a freestanding medical respite program and moved somewhat backwards into the healthcare for the homeless primary and preventative care space. So today we operate both models and have been able to leverage our state's Medicaid expansion in 2014 to pursue that opportunity, but we initially, and what we consider our flagship model, and is what is very much at the heart of all we do, is medical respite care for the homeless. Just a few sentences about our model. As Julia and Brenda mentioned, we're a 50-bed freestanding center. We're a 24/7, and I would say we are an integrated medical and social service model, in that we have both array of services on staff, co-located in the facility, in addition to a fairly limited array of behavioral health services as well. We staff a medical team and a nursing team. We have nurses available 24/7 simply because of the acuity of the patients that we're providing care to really compel that level of around-the-clock licensed presence. We have independent medical practitioners on site every day. So typically that's referring to some combination of a MD, physician's assistant, and or a nurse practitioner. And as our length of stay, average length of stay, has fallen over each of the 5 years we've been open, we've been able to leverage our beds into about 500 unique individual engagements per year. As you can imagine, with a fixed capacity of beds, that number only goes up when length of stay falls, much like a hospital. Julia mentioned that I tend to be on the transparent side of finances and sharing financial information about our respite program. I can't help but wonder what I'm missing, and if I'm just not smart enough to be secretive. But I suppose your loss is my gain. I'm going to show you 2 slides here that give you the same information sliced and diced 2 different ways. The first is a year-over-year growth of our respite program budget. This growth has naturally occurred really to meet the needs of the local community, both with regards to the rate at which we're turning people through our respite center. As I mentioned, the pressure has been downward on our length of stay, and the pressure has also been downward in that we are really not to compromise patient outcomes as we trade off for shorter lengths of stay. So that's created the need for new and additional and different services available on site, and then also investing in the frequency and amount of services provided at the center to meet the relatively high acuity of the medical conditions of the patients we look to serve. So this gives you an idea that our initial founding budget was just under $2.5 million and has grown to upwards of $4 million in our current fiscal year. What maybe is more interesting to you would be the journey we've been on from the perspective of how we fund our services. You could probably mentally draw a line between fiscal year 2014 and fiscal year 2015, even if I hadn't told you, and guess that that is the time in which our state expanded Medicaid eligibility to childless adults. So that really put some pressure on us to better understand the shift from hospitals being at risk for poor outcomes among their homeless patients, and that risk effectively being shifted out to the health plans who are insuring these individuals. That compelled us to recalibrate our business model to be reflective of Medicaid funding and those Medicaid managed care organizations who effectively have skin in the game now, coming to the table and funding the services that we provide, knowing that we're very much bending the cost curve and reining in future utilization and various expenses for the people we're taking care of. You can see that there are several funding sources coming together. You're going to hear me say this probably a couple times in this webinar. There is absolutely no set recipe for funding medical respite, and if you're looking for one in today's current day and age, you're simply not going to find one. In fact, you're going to be hard-pressed to hold a funding model in medical respite static year over year in our current healthcare environment. So when I provide technical assistance, one of the questions I always get asked is, how do you come up with your model? And I say, which year? It's an ever-evolving process, and there's fluidity to this that organizations really have to become comfortable with in order to take the leap. There is, as a provider of medical respite care, I typically say there is not a funding source I don't like or that I won't explore. We do not, unfortunately, have the luxury of being a quote-unquote Medicaid-funded respite program or a HUD-funded respite program or a hospital-funded respite program. And in fact, when you look around the country, especially among those organizations that are privately held, the vast majority of them are piecing together a diverse array of funds from across the private sector, the healthcare sector, and the government/social services sector. So I would encourage you, if you're looking into making respite happen in your community, get very comfortable with the fluid nature of this work and the funding that props it up. This is the same information, just normalized to growth. So in other words, it's not showing the growth of the budget year over year. It's simply showing how the relative funding streams have offset the budget as a percentage rather than as a total budget. Much, again, of the same information. I'm not going to spend a whole lot of time here. I believe these slides will be made available to you after the presentation, and you can dig into that and certainly email me if there's additional questions. All right, I think with that, we're going to move back in to a Q&A discussion, facilitated discussion session. So I'll hand it back to Barbara and Julia.
Thank you so much. Brandon, Julia, Brenda, I think that's the kind of information that just your experiences and what you're seeing is really helping shape as people think about what this looks like for them. So with that, all that in mind, and all of you are coming from very different perspectives, let's just plunge into some of the discussion here. I think one thing, I had talked earlier about the rationale for having medical respite in your community, but from your perspective, what do you think is motivating the increased interest in respite programs that we're seeing right now? Brandon, why don't I start with you?
Well, respite, I think, fits at the heart of a lot of kind of key pillars to healthcare reform, and regardless of what administration is leading the healthcare reform, I think some of the fundamental truths that are behind it and that will be universal to every administration into the future as we move forward is moving medical care from outside the traditional expensive inpatient setting out into more innovative community-based settings. And respite is kind of the perfect marriage of medical need and also leveraging the other infrastructure in the community to meet the social needs of the patient. We've had an unprecedented amount of focus in the healthcare sector in the last 2 to 3 years on the social determinants of health, even going so far as to give it that name. And now we all know what we're talking about, even though HCH programs have known this for 2 decades. We now are talking about the social determinants as if it's an revolutionary, innovative concept. And respite centers are so well positioned to talk about everything that's important to the agencies that have traditionally been the big players in this space, whether it's the social determinant issue, whether it's bending the cost curve, whether it's high utilizers, poor outcomes resulting from issues of poverty. We are so well positioned to be subject matter experts in a space that's of great interest to the rest of the healthcare community.
Thank you. And Julia or Brenda, any additional thoughts to that?
I agree with Brandon and think that both managed care plans as well as hospitals are so focused right now on their high-cost patients that the financial argument is very, very powerful. And at the same time, in so many of our urban areas particularly, but also in rural areas, there's been a heightened awareness around homelessness and an interest in supporting services around homelessness and improving outcomes. And so it's been interesting in terms of looking at funding and where the funding comes from to see that hospitals have, who were never at the table before in our community in the last few years, have really come forward, and both through their operational dollars as well as their community benefits dollars, and they've been also marrying the two of those things, their focus on community benefits as well as the impact on their operations of serving a high-risk population.
Julia, anything to add?
I agree.
And so I think with all of that, and I know you've talked about cost and hospitals taking a look at frequent users and some of the outcome measures. What opportunities do you think are present in this current environment that specifically give respite programs an advantage? I know you did talk about social determinants of health, but is there any more detail that you would provide about those opportunities there?
This is Julia, and I do think it's such, what we're hearing in terms of TA requests is people are really seeing this as the gap in their community, and this is where people are really falling through the cracks, and it's such an opportunity for people to be wrapped around in services, and that's one of, I think, the strengths of medical respite care, and what makes it so unique is that it's a time for somebody to 100% focus on healing, and while they're healing, you can start with the self-management and goal setting and planning and enrolling them in services, and so I think that's one of the unique things about medical respite that more communities are seeing, is that it's really this opportunity to just get people connected so that they don't keep cycling in and out.
This is Brenda. I also think that there's a focus in it, and respite program is a piece of this focus on care transitions in general, and the linkages between institutions, whether those be hospitals or skilled nursing facilities, and primary care, and the role of primary care and being the catcher for people as they come out of the hospital or come out of the SNF, and that we can take advantage of the system getting more organized around these care transitions to promote respite programs as a key component.
This is Brandon. I think the couple things that come to my mind around the current environment that give us a leg up is the advent of accountable care organizations and the emphasis on those into the future. More and more organizations or healthcare entities are going to be responsible for the entire cost of care, and it opens up the book to innovation. I can't tell you, and maybe this is bleeding into the next question a little bit, but I can't tell you how many times I've been asked the question, what is the code for medical respite care? How do I bill medical respite care? And I wish there was a CPT code I could give you, but there isn't. And so what that really compels every respite entity to do is who wants to be in the healthcare space at least, is to engage with local accountable care organizations or managed care entities that are at risk for the bad outcomes that your population is currently experiencing. And don't try to be the subject matter expert. Don't try to go to the table telling them what code you want to bill, and don't feel like you have to know that. Come to the table with your solution to a problem that's costing them money, and let them figure out and tell you what the best way to get paid for providing the services. The only other thing I'd throw in here is the shameless plug for the RCP and standards that were just published a few months ago. And when you talk about opportunities that exist today that didn't exist even a year ago, there is a nationally recognized set of standards for respite centers now publicly available, and it serves as a step-by-step implementation guide when you're looking at policy, services, partnerships that you're going to need. That really should be your foundation as you're building and planning a program. And I'd encourage you to look that up on the National Council's website and use them to your content.
Thank you for that plug for the standards. And you had started even a great thread there, too, on not coding, but billing and what codes to bill. And so that leads us to our question about challenges to overcome, particularly around financing. So did you want to pick up that thread a little bit more, Brandon, or hand it off to someone else?
You know, I think I said my piece about coding. The only other challenge that really resonates with me when I reflect back is simply the question of when to take the leap, because you're looking at as I've already stated, a model that's fluid with no concrete replicable framework for funding. The toughest question isn't always how to model it or how to piece together the services. It's when do you feel like your boat is close enough to the dock that you can jump. And I think that for me and for many others is the challenge, is when do you have enough pieces in place and when do you have enough funding mechanisms lined up that you can take the leap. Because the truth is many of the financial resources that you're going to secure as a respite program into the future simply aren't going to be made available to you at the start, just because nobody's writing a check for an idea. And it's amazing how the conversation changes when you get into the reality of it and you have a bed and you have a place that the local hospital and healthcare community can refer patients to. The entire reality of the conversation changes overnight. So I think you, at some point in this space, you take a leap and do it. And I think that's the challenge and the part that frightens everyone, myself included.
Yeah, this is Julia. I agree. I think that's part of some of the issues that programs talk to us about as well, and we really encourage people to start with a pilot program. I mean, you don't have to open your doors with the services you are hoping to be providing in 5 years. It's find 2 beds, find out how to make it work, and learn as you go. And that's true with the standards as well. I think the standards are really foundational and helpful for building your program, but there are very few programs that will open their doors and meet every single aspect of the standards on day one. So I think the most important piece is starting and not waiting until everything is in place, because it won't probably ever all be in place.
This is Brenda. I mean, that's really exactly what we did. We didn't have standards. We didn't have beds. We just decided it was time to do it and we would make it happen. And we did have a willing partner to pay for it. And it's changing as we speak in terms of our local model. And I don't know where it's going. I would love to get to the point where we actually have a building that's really made for respite care, but that's not even in the picture yet. And other agencies are also providing some respite care in our community, and we're looking at, well, should we be financing this through a big pool so that it's all more of a system of care as opposed to piecemeal. But we just decided it was time. We needed the service, and it wasn't going to be perfect. But as long as we could break even, we'd try and do it and see what happened and fix it as we went along.
And you had talked originally, earlier in your comments, about when you were first putting this together and you were trying to make the case. I think that moves us to our next question about what did you say, or how did you lay out the case for justifying getting even some funding to be able to start your program?
In our case, in the East Bay, there was the hospitals were interested, and the homeless service community was interested, and we finally just sat down with each other and said, how can we make this happen? How can we start this very, very simply? We started looking at some of the data. It was very, very difficult for the hospitals to actually give us any hard data on how many homeless individuals they were caring for or discharging on a weekly or monthly basis. But there was enough anecdotal data and some, a little bit of hard data to say, well, we know we have enough volume of folks who are needing a place to stay to justify 5 beds to start. We'll just start small and see if we fill those beds. And if we fill those beds and we're having to turn people away, then we'll look at expanding. I think, it was at the same time that the hospitals were starting to be planning around avoiding fines for readmissions. There had been a lot of social media around people who had been discharged to homelessness, who were, there were videos of people with IVs walking on the streets. And it just, in a way, where it was a little bit of a perfect storm. But I think that there's also plenty of research out there about the savings and the quality outcomes, and we don't need to reinvent a lot of that. So I also went looking online at the council website and getting data and showing, that it made sense from a financial point of view.
I would suggest the most straightforward way is probably to tailor a very specific, concise message that's unique to the audience you're talking to. The same rationale for medical respite for hospitals does not resonate with health plans and typically does not resonate with philanthropic entities or even the general public. So you really have to have a concise way of tailoring your proposal to address the greatest pain points for the target audience. So for hospitals, we all know that there's lots of readmission and quality-based initiatives, but at the end of the day, the greatest expense threat to hospitals is their beds are clogged by underinsured or uninsured homeless individuals that are displacing people that have better insurance benefits. And the truth is that's 80%, that's 80 of the 80-20 rule is around the opportunity cost of having to care for this population and their recidivism. So your pitch to the hospital has got to be around getting people out sooner and keeping them out longer. Health plans, it's more of a longitudinal, long-term cost conversation. You are going to bend the cost curve for very expensive, high-risk individuals. And then candidly, sometimes I fall into the temptation of talking about those two issues way too much. And thankfully, I work shoulder to shoulder with a founder who's a sister of St. Joseph of Carondelet, and she sometimes just looks at me and goes, think what it's like to be this person. Think, just the humanitarian pitch of this whole thing is what the general population and the surrounding community need to stay in touch with. It's how miserable it is to be homeless and without the care you need during periods of illness or injury. So tailor to your audience is the best advice I can give.
Can I also add that we've definitely found that identifying the person or people in whatever institution you're talking to who are already thinking about these issues in whatever aspect, whether it's saving money or have an inclination to serving the population, that's made a tremendous difference for us, that we've had many deaf ears, but when we found the right person to just at least open the door for us and get our foot in the door, it's made an enormous difference. And you just have to keep looking for that person and having the conversations and not giving up.
That's really good advice. And I think in the interest of time, too, we've had a number of questions come in around some of the topics that you've hit. And so I wanted to come, we'll leave these discussion questions here on the slide just for a moment. One of our attendees has asked, can you describe the involvement of SNFs in medical respite now, or opportunities or downsides of working with them? And sorry for the use of the acronym, skilled nursing facility. Any thoughts about how they work as partners?
I can speak a little bit to our experience in that regard. So our service array has a little bit of overlap into the SNF level of care, and specifically with reference to wound care services that we provide on site. And we do maintenance of IV infusion therapies at our facility. And so those are historically services that can be pushed out to SNFs if they don't come to us. And so in a very limited regard, we've been perceived as competitors on occasion, but more recently, we've become more of a care extender of SNFs who are under much tighter regulation from a benefit perspective typically than we are, and who really have the same burden as hospitals to get people out of their facilities in a timely manner, but oftentimes with even fewer resources financially than hospitals have. So I think SNFs, and unfortunately, you can't really, that's kind of like saying, are all hospitals good partners? The truth is some are and some aren't, and SNFs are the same way, and as far as what their treatment philosophy is, their orientation toward the poor is. There's some great partners in this space, and candidly, we're the safety net for some of our local SNF dumps. And we try to focus on the good partnerships we have and educate those others that sometimes we're not as coordinated with as we should be.
This is Julie. I just want to add quickly, I agree with that, and that I think in partnering, there are a lot of opportunities in terms of partnering with SNFs, but it might be the respite program really carrying the burden of educating staff around serving the population and the philosophy of medical respite. So, and making sure the services are in line with that. So.
I think, and one of the things that, and again, some of the themes that you've all touched on, we had a question about some of the anti-dumping laws. And so the question is, do any of your local governments have additional regulations in addition to the federal EMTALA law that prevent patient dumping, or have you used respite as an opportunity to add to the rationale for respite by strengthening their discharge processes? And so I'm curious what that conversation may look like for you.
This is Brenda. There aren't any additional regulations, but that's definitely been a selling point, is that with the access to medical respite, that the hospital is really able to ethically discharge their patients. And certainly, and this connects to the last question, is that the SNFs now also will not take anybody unless they have a discharge address from the hospital. So that has been an opportunity for the hospital to move the person along from the hospital to the SNF, and for the SNF to feel confident that they are going to be able to follow regulation and discharge somebody to an actual address.
And I'm the same as Brenda. I certainly wish we had some better laws that could prohibit that practice and establish higher levels of accountability and advocacy for the people that are vulnerable at discharge. But in Arizona, we simply don't have that. It's central to the conversation, especially on the value proposition side to the hospitals. You know, as I said earlier, we're going to get them out sooner, and we're going to get them out safely. And that's really what you're not saying, is you don't have to dump anymore if that's your orientation. Or some of our hospital partners are much more conservative and would keep people in for very long, expensive lengths of stay if they were really risk averse on the discharge decision-making front.
And Julia, do you have anything to add to that before I move on?
Not particularly. No, that sounds good.
So here's a straightforward question. Could either presenter give an average cost per bed? And I want to do that. Your disclaimer ahead of time is that a lot of times costs and budgets can be proprietary information, and people do tend to either not be at liberty to disclose that. And so I just want to put that out there, that that's very common, is people would love to share but are prohibited by the agreements they have with their funders. So with that disclaimer in mind, are either one of you, or Julia, maybe you have an idea of a national average on the cost per bed?
This is Brandon. I'm happy. Like I said, I'm probably not smart enough to be proprietary with information, but you know, certainly, and to speak to your disclaimer, Barbara, I'm not supposed to talk about what's in our payment contract, but that has nothing to do with cost. I wish it did, but it isn't always synonymous with what the cost of services are, and unfortunately, it's sometimes less. But I can tell you, if you recall our graph, we've had a year-over-year growth for 5 years now in the array of services we provide and the frequency with which we provide them to a patient. So we've seen our cost per day rise every year over 5 years, but simultaneously our length of stay shorten. So every patient's actually getting cheaper, even though our cost per day has gone up. And I can tell you the range from where we've been when we opened to where we are now has been between $220 and about $315, if that helps.
And our cost per day in a very, very simple model is more like $80 per day. But remember, that's basically with a non-licensed case manager and a little add-on RN.
Julia, I'll give you the last word.
Yeah, I was just going to say right in line with that, just on average in terms of hospital payment for beds, it's between $50 and $325. And that really depends on the acuity level, and yeah, so that's not super helpful, but yeah, it's super dependent on the acuity level of the patients coming out of the hospital.
Thank you all. We're at time, and I feel like there's so much more content that we could do. We didn't even get through our own questions, but I think that this is a conversation that we will be coming back to at the council because this is such a growth area. I just want to thank my presenters, Julia, Brenda, and Brandon. Your expertise here is really great. Thank you all for being leaders in this field. Just want to remind everyone that this webinar will be archived on our website within 3 days. The slides will be available, and this will be emailed to anyone who was registered for the event. So